there's still enormous amounts of interest by NHS Trusts to use the skills of medical doctors and clinicians who are refugees, not surprisingly because of the shortage. And there's still a lot of interest in the medical support workers scheme, how it worked in those 2 years, and how it was successful. And so today's seminar really is focusing on 2 exemplar sites which tried and implemented the medical support worker scheme to great effect, and how best to do this. And I will provide some information as well as some context, as you can see, from people who will be talking about it from those trusts. So we hope that today the objective really is to help you understand the scheme, help to encourage interested trusts to join it, and also to put you in contact with some of the people who will be talking today, who can help you make a scheme very successful and support you in the way that you develop it if you want to go ahead. So that's the sort of background. In terms of just a few more housekeeping before we start the schedule today. I think you probably all know how to use Zoom. Just a note that there's a Q&A box, so please ask questions. We'll get to a Q&A towards the end of the seminar. We will be finishing at 1 o'clock on the dot. We are going to be videoing this webinar, so we can spread this far and wide to a lot of people who want to join but did not join today because they can't join live. So we'll be spreading this out through our networks. So it's recorded. And I think that's all I need to say. Just don't forget to ask your questions. And I'm going to then kick off by introducing Craig D'Souza, who's our first speaker. Now, Craig is the Director of Workforce Supply at NHS England and is really the nominal head, I would say, Craig, of what was the Medical Support Workers Scheme, who's going to tell us about the origin of the scheme, how it works, and the current state of the scheme. So thank you very much, Craig.
Thanks, Jennifer, and good morning, everyone. I'm an ex-provider HR director, and I came to NHS England in November 2020 as part of the COVID vaccine deployment programme. And it was there that I learned of the excellent work that was being progressed on the back of the NHS Bringing Back Staff scheme. So if many of you remember the big call that went out across the country for retired practitioners to return to assist with the response to the pandemic. As a result of that call, there was a phenomenal response, and what our National Medical Directorate did at the time was they thought there is a lot of capacity of people who are not currently registered who could provide a response, and there was born sort of the Medical Support Worker Scheme. It was intended to be a vehicle mainly to take retired practitioners, but as a result of progressing that, there was a realization that there was a lot of really talented and skilled people across the country who came from refugee backgrounds, and in there I think lied sort of the first look in terms of the potential for the scheme. So throughout the pandemic, the scheme was set up to provide direct salary support. A small number of trusts led the way in terms of implementing a new role, a new model in terms of employment to support these people to be able to deliver a pandemic response, but equally to give those individuals exposure and experience to the health service that has then led them to be able to progress to achieving GMC registration ultimately. So the scheme ran for the 3 years throughout the pandemic. It was highly successful. I think there was really good engagement across with the organisations that have taken this forward. And I think we've learned a lot throughout the journey over time. It started off as a very, very prescriptive model in terms of you must do this, you must employ them this way, you must have that job description. And that throughout the lifetime of the programme, we've moved to more of actually what is the NHS all about, is that actually it needs to be models, there needs to be frames, but actually the real magic that happens is when this is created and delivered locally. And so over time, sort of that learning has been embedded, and there have been more flexibilities that were brought into the scheme. We then came to last year, which was when we originally had an allocation of money from the Department of Health and Social Care for a continuation of another year's worth of the scheme. But as many of you will know, certainly this financial year and last financial year was extremely pressured financially, and as a result, we at NHS England had to make decisions around a number of national programmes, and unfortunately this one was one that we couldn't continue to provide the salary support that we had done in previous years. that gave us an important opportunity to reflect around. We've been doing this for a while within NHS England, but as with all national programmes have to reach a point where the magic continues to happen at a local level. And I think what we've been doing in the in-between is starting to think about, whilst there is no money, is that how do we leverage the impact and the experiences of our exemplar sites, codifying that into best practice and providing the tools to allow organisations to take forward with actually taking these schemes locally. I think we've seen there is a true case for this type of scheme. It provides immense benefits for local communities and an opportunity for NHS organisations to engage with their local populations and to find people who have got those talent and skills and help them come into the NHS workforce through an experience that gives them exposure to the health system, the ability to learn, and also the skills to be able to navigate so that they can ultimately achieve registration and secure a role. So where we are at now is that we have produced significant amounts of guidance, tools, frames. I think today is a good opportunity to showcase about some of the magic that's happened in terms of across the country, but also to do that inspiration about how do we now take this from being a national programme to an embedded role that is part of NHS organisations and make this a sustainable approach. Jennifer, I hope that's a good starter in terms of sort of the conversation, in terms of the context where we're at and where we're going to. You're on mute, Jennifer.
Dear, after 5 years, that's bad, isn't it? Thank you very much, Craig. I think that does. And just a quick question from me, if I might, as chair, just to say, in terms of the benefits to trusts for the outlay, particularly if it's not nationally funded any longer, how strong are those benefits in terms of being very concretely described at the moment, or are we still collecting information on that?
We have some articulation for our national resources, but I think it's one of those things that we want to continuously learn and build on more. For me, I think the benefits here are NHS organisation playing their key role as anchor institutes, engaging with their local communities. But for the individuals, it's giving people access into medical careers and actually taking control of your workforce growth, which is a key part of the NHS long-term workforce plan.
Yes, good. Sorry, thank you. And just a very quick one. Is this, there's a question, is this was it also eligible to in primary care or just NHS Trusts?
No, it most certainly was eligible to primary care. So we had some really great examples of PCNs that engaged with the programme as well, and we supported them to take that forward.
Very interesting. And there's some guidance on that nationally available for interested primary care trusts and networks.
There is, yes.
Yeah. Yeah, excellent. Thank you so much, Craig. Good. So we now then move on to the two examples. And I'm going to start off with Johan from Chelsea and Westminster. Thank you, Johan.
Thank you, Jennifer. Very good morning to you all. I'm here from the medical workforce team at Chelsea and Westminster Hospital Trust to share outcomes of the medical support worker batch we had in 2022. The journey started with us when we got some CVs in around second quarter of 22, and we managed to select 5 candidates. If I remember, it was 3 in medicine, 1 in obs and gynae, and 1 in A&E department. Their journey began when they officially started with us in August 22, as we welcomed them along with our junior doctors during the big August rotation round. And as we all know, even though our team was very busy with the August rotation, we kind of didn't let this program go loose because we definitely knew this would add big value to our wider medical workforce. Once they were in the program, they were allocated a supervising consultant, and they were responsible to mold them into the culture and integrate them into the wider team within their specialty. Though they were allocated a supervising consultant, they were also guided by educational supervisor, and we made a point to involve our medical education team to ensure they were continuously being monitored and supported. And as days, months passed, we started getting very good feedback about the medical support workers from the teams. Even when we checked with the individual candidates, they were very happy with the progress in our trust. And eventually, when the funding stopped somewhere in March 23, we had to make some plans. Side by side, two of them uh, moved, and they were also nearing their Pleb 2 completion. And I'm happy to say that three of them were actually offered roles within our trust as junior doctors, commencing from August 23. Though currently we have just one of them still working with us, the others I can see are still supporting us with ad hoc bank duties and stuff. So it's good to see that they are in touch some way or the other. And I must really credit our clinical teams, clinical departments for well integrating this program within their specialty, given the concept was very new for most of them. We also did get clear guidance from NHS England, and with which we were able to capitalize clear rules for educational supervisors, clear role for supervising consultant, what our medical education team should do. So I think that all that contributed to the clear success. And from doctors' perspective, the doctors could now I can call them doctors. From their perspective, they were already being shaped and ready to be fit in the NHS right from their GMC registration stage. And today, I'm sure the doctor who we currently has as junior doctor is also on the discussion of their career pathways, be it in the view of long-term view of being a specialty doctor or through becoming a long consultant through CSER program. So we are happy that we were able to retain this doctor and make some long-term plans for them. Following the success of this batch, there were a lot of triggers and ideas about international medical graduates that came into our minds. A lot of focus was then shifted to IMGs. So our trust currently runs two major programs, and all credits to our education center and postgrad team. So one such program is the clinical attachment team, which is open for those seeking roles as doctors in the NHS. They may be already have GMC registered, or they may be on their GMC pathway, registration pathway. And the second program is the IMG induction. This is exclusively for new starters who are new into the NHS. And this program is extensive 5-day induction program where the IMGs are inducted into the NHS settings. They are supported to clear any doubts they have, be it from aspects of how to get UK bank account, how to do UK DBS, what's NHS pension, or it may be appraisal and revalidation with GMC. And so far, I can say these programs are running very well. They're very well welcomed by the IMG doctors. And I'm also happy to say that from the clinical attachment programs we are able to identify potential doctors who can then start with us as junior clinical fellows. We also highlight importance of building a good application, how to answer good interviews during this clinical attachment induction programs, which is very well welcome and beneficial. I mean, there is definitely a lot we can do to innovate to cut gaps in our workforce, particularly finding ways to fill in hard to recruit roles. And we also recently held an overseas recruitment drive for doctors, which was very successful because we ended up offering over 20 doctors within the acute medicine, general medicine, and A&E. To highlight, as a trust, we got good support from NHSE. There were clear instructions at every stage, including smooth processing of invoices with finance. The overall scheme was a morale booster for doctors pursuing GMC registration. The current batch which we had became an inspiration to international graduates. Also, if we closely look at the NHS long-term workforce plan, there are estimates that the workforce gap is going to be around 360,000 by 2036. And there are 3 action points highlighted: train, retain, and reform. And this scheme, MSW scheme for us, was one such medium, because the examples which I gave, we were able to train the MSWs to become good potential within the NHS, and we were able to offer 3 of them. And I'm sure even though we were able to offer 3 and we have just 1 now, the others, wherever they are, and they are still talking about us, and they're still in touch with us somehow. So I think, yeah, that was about train and retain. And reform, again, is a larger picture which involves a collaborative approach with different stakeholders. And as I highly speak about the program and the doctors which we had, I'm sure if we ask anything to the current doctor which we have, she too will have lots to say about how the program went through and how it helped shaping her career pathway. And as a trust, we've always happy to support them right from the start till now. And we are also happy to provide more guidance to them to their future journeys. On final note, we did have success. So I would like to highly say that we had success with the MSW scheme, and we are now capitalizing on the potentials of the IMGs in our trust. The scheme was not just a success for this one doctor which we currently had, and not just for the 5 IMGs which we had, but as a trust, it was a big benefit for us. And I'm sure as a it's going to be a benefit for the big NHS as a whole as well. Thank you.
Thank you very much. Just on that last note, the kinds of benefits using if from the MSW scheme to the trust, apart from being able to have committed doctors now that you have access to through the refugee route, was there anything more you wanted to add there about the benefits and how these refugees doctors felt about working in the trust and their contribution?
I mean, it was all a trigger point because of this MSW scheme. The whole focus shifted on the IMGs, and
Right.
it may have started with the 5 candidates we had, but potentially we ended up getting 21 more IMGs when we had overseas recruitment drive.
Right.
So it was a big trigger and very widely welcomed by each specialty. We had interest from medicine team mostly, an acute medicine team. Then we had the others, like the A&E team got involved. Now we're having anesthetics team which are getting involved. So we have hard to recruit roles at senior tiers. So we are looking at potential of developing them right from the start, and then they become junior doctors, and then they move to a senior specialty registrar and then consultant. So we're trying to bridge that gap right from the start.
Yes. And so have I understood correctly that the structures that you set up and the culture you set up, which started with the MSW scheme, then was able to be expanded to cope with, to go out to the international medical graduates?
Yes, of course. I mean, a lot of focus then shifted on the IMGs, and we are tapping that potential now.
Great stuff. Thank you. Now, there's a few questions, practical questions. We have got a few minutes in your slot, Johan, so I will ask you those questions right now. So the first one was a practical one, which is, do you provide PA remuneration for the MSW supervisors?
I'm not sure about that, but I think that would be remunerated through the PAs allocated for the educational supervisors. So these educational supervisors were common for our current junior doctors and medical support workers. So I believe it would be embedded in the same PAs where they would
be part of that support structure.
Yeah.
Thank you. And then, does Chelsea Westminster charge IMGs for clinical attachments? If so, how much and what does this cover?
No, there's no charge for them because it's in turn a benefit for us because we are able to tap them as a potential junior doctors.
Fantastic. And then there's something here about how do you ensure retention? Candidates might go elsewhere, as I think you were saying. And given all the outlay that you make for these for the MSWs, some will go elsewhere. There's a kind of collective benefit to the NHS, but how do you think of that at the trust? Are you happy to lose some of them to elsewhere?
I mean, that's always a challenge for us, because we kind of face that for every situation. We kind of train them even for junior doctors, we train them and they move out as a senior doctor elsewhere. I mean, yes, one thing you highlighted is it's more of a overall benefit for the entire NHS. But what we noticed is if they leave, if they go elsewhere, then during the next rotation in 1 or 2 years, they end up coming back.
Lovely. Yeah.
I mean, we have like more learning from them when they come back, and we're always happy to support them further. And it's good that they always kind of remain in touch with us through bank shifts or something, and we're always welcoming them back when they come up with more knowledge and more expertise.
That sounds a great testimony, doesn't it? So thank you very much. Well, we've got lots of questions here, but I'm going to, please, those of you who asked, don't worry, I'm going to save them up for the Q&A session. We're not going to lose your questions. So thank you, Johan. And we'll have part 2 here because we have Heike Bojar from Bart's Health Trust, who I know is deeply committed to this programme. And Heike, please tell us all about your fine work.
Thank you very much, Jennifer. Yes, good morning to you all, and I'm very grateful to be able to show you how we have done that at the Royal London. May I have the next slide, please? So, as a background, at one point, we had the largest intensive care unit in Europe during especially the second wave of the pandemic, and we were quickly running out of staff. Our very first medical support worker was a chance appointment. My role during the pandemic was to head the medical redeployment, to get all the other doctors onto the ITU and create, I think at one point we had 15 daily extra rotas and we were running out of people. And I was contacted by a Ukrainian anesthetist who was not GMC registered, and she worked as a healthcare support worker in our recovery. And she said to me, I've asked so many people, nobody has heard of this scheme. And I hadn't either at that point. And I looked at it and I thought, my God, why are we not doing this? So it was relatively calm. She kind of came at the right time to the right person in the right place. We wrote a job description for her. I was sitting with senior HR at the time in the redeployment office, very quickly onboarded her. And by the time the second wave really hit us, we had everything in place and we started appointing as many MSWs as we safely could at the time, which was somewhere between 2 and 4 a week. And may I have the next slide, please? So this is just to show the first cohort went straight to ITU. And this is really learning by doing. In hindsight, I think, oh my God, how could have sent people, refugees from war areas, straight onto our high-tech ITU? They must have thought they landed on Mars. And it worked amazingly well. One of them was a radiologist. He had not a clue what he was doing, but they were all, of course, in supportive roles. But he quickly took initiative and gathered other people around him, did morning extra X-ray sessions with everyone. So that was all really positive. And once our ITU disbanded in March, we just had a very few staying on ITU, and people then moved into their area of expertise or where they wanted to work. And because I was in redeployment, I knew all the heads of department and could really quite well negotiate for them to accept MSWs. Because everybody was tired, we were so exhausted after the pandemic. It was a hard sell at times. You consultants would meet in the corridor and really burst out in tears from sheer exhaustion. So some people were saying, "Gosh, why would we take this on?" But it became feel-good thing is perhaps not the right word, but we felt they give us more than we give them in some ways. And then in the third year, we had really expanded further. So I think our headcount at the time was 45 to 50. And as soon as somebody gained GMC registration, they were very quick to move out, get a job, and we backfilled the post. Our first appointments all came through NHS England, and then through word of mouth, I think we could have filled hundreds of posts all the time. And I'm still getting many applications daily. Next slide, bitte, please. And so I started with asking people, could you write me a little report about how you experience coming to the NHS, especially in contrast to where you've come from? And I can't believe a nurse is allowed to ask a doctor a question here. Or where I come from, the patient is the least important person in the room. So we quickly realized people came from a very different healthcare system, often quite hierarchical, paternalistic, really kind of the opposite of what we're trying to do in the NHS. And this then informed how we targeted our training. And by the way, on the photograph, you see Yen, who is from Kharkiv in the Ukraine, and she is one of our MSWs who managed all the conversion exams in absolute record time of just 1 year. So this is a highly motivated workforce. Next slide, please. And so really, we felt quite early on, everybody can learn medicine. That's not that difficult, but the cultural integration is key here. So as Johan said, we also gave named supervisors who would have regular meetings with our MSW, and we buddied them up with a trainee. And often these trainees were also handpicked, people who wanted this role, this guiding role. Diversity training, the guardian of free speech came regularly and told our MSWs about the rights they have in the NHS, where to complain if they feel they are undermined or were discriminated against. LGBTQ plus workshops, not that obvious, but then we realized in a number of countries where our MSWs came from, it is illegal to be gay, or there's even the death penalty. So we did quite extensive workshops with really fantastic trainers that were very well received. We ensured we had psychology support, and we were in a lucky position because we had a very experienced team of clinical psychologists after the pandemic, just for staff in my trust. And they embraced the MSWs. We had monthly meetings. We were quite careful because we're aware that there is a big stigma still on psychologists. So we called it the wellbeing group. And
we're just having a few audio problems. Heike has frozen. I think she may well come back. I didn't say in the introduction, Heike has joined us from abroad because she's on holiday. She's so committed. She wanted to take part in this webinar. So I'm not sure where she is exactly, but she's clearly having some issues there. I think what we'll do is to just pause Heike while she's sorting herself out.
Oops.
Are you back? Oh, there you are.
I'm back. I'm so sorry. I don't know what has happened.
I was busy telling everybody you were on holiday, Heike, and how wonderful it was you're speaking. Where are you speaking from, by the way?
Oh, from a nice from Dresden.
Oh, okay.
Anyway, apologies.
Right.
I'm back.
Thank you.
So we were talking about the psychology support, pastoral care. We as a team were all very available at all times. And we, you would get a phone call at 3 a.m. Somebody's mum had died in Syria and he had nobody to phone, or the amount of marriage guidance even we were asked to give. It was quite extraordinary. One MSW said to me, gosh, you are my family here. We haven't got anybody that we can talk to. Outings from, you know, meeting up and everybody brings a dish from their country, to going to Borough Markets, going on history tours in London. So we tried to do at least once a month to do something social. And peer support, of course, so people knew there was a group of them and had a group identity, which was very important for especially our refugee doctors. Next slide, please. And we worked very closely with RAGU, which is in London, of course, the Refugee Assessment and Guidance Unit, the Refugee Council. We would meet regularly and talk through candidates, and everybody who was referred from them to us was outstanding. They were so well prepared, and that was a really, really fruitful collaboration, especially if there were any hiccups, any problems that we could then discuss and help. The GMC, we had many meetings with especially the admission team, GP Training Hub, other trusts. Next slide, please. And we very quickly formed a network of London providers of all the trusts, bigger, smaller. We met every 2 weeks, just exchange experiences or discuss problems. Smaller trusts only had 1 or 2 MSWs, sometimes had questions how we managed any issues. We set up monthly online teaching for all the London MSWs, and there were regularly over 100 MSWs present. And we just picked important topics from Mental Health Act in the UK, consent issues. So all the things that even our own trainees occasionally would stumble over. We ran a pilot with primary care, where we had a few MSWs who were mostly interested in being a GP. So they would be 3 times in medicine with us and 2 days in a training practice. And that worked out very well. And one of our sites had a very good foundation training for refugee doctors, which also we work quite closely with each other. Next slide, please. Just very briefly, people come from all over the place. I work in a very diverse trust. I think we have 220 languages spoken in our trust, so they fit right in. Next one, please. And I think on the next photo, I could cry every time I see this photograph. Mohammed from Syria, you can see how he managed to come to the UK. He is the radiologist I talked about at the very beginning. He is now an ST6 in East Sussex, and he is consultant level. His life has been turned around. Next one, please. And the next one is Ahlam from Yemen. And you can see a photograph of her home hospital before she left. And she was shocked when she arrived on our ITU. It must have looked like Mars for her when she arrived. Few weeks later, she passed MRCP, and she is now a medical registrar in respiratory medicine. Next one, please. And really going forward, we have such a highly motivated, dedicated medical workforce here. These people are not slackers. They come on time, they stay long, they really go the extra mile. They appreciate the huge opportunity they've been given here. Many of them are very experienced and bring clinical value and really contribute in so many ways. And of course, are part of a very diverse working stream. Next slide, please. And it's an absolute win-win for everyone. And just in our trust alone, over those 3 years, we had over 70 IMGs who gained full GMC registration. And some of them worked as clinical fellows, some went straight into locum consultant posts. We have so many really highly skilled people. And talking about highly skilled, on the photograph, you see Sasha. He is a Ukrainian orthopedic surgeon from the Ukraine. he has never learned English and is really struggling with the language. In the last 2 years, he's been working on building sites and in kitchens. He is a fully trained orthopedic surgeon. We can't, we are wasting a lot of talent by not tapping into this. Next slide, please. And really what we would love to see is the MSWs as a formal entry path into the NHS, like any other, with a really structured national program. I feel there's got to be some central funding, because to make this work and make it safe, all the MSWs have to be supernumerary. And especially initially, there is a lot of training cost involved, energy involved to bring them up to speed. We need educational and admin support, and especially engagement also with the Royal Colleges. Of over 130 MSWs who we have had over the last 3 years, only 2 have managed to get a training number, which was very, very difficult to break into. And also giving, for example, there are so many doctors in this country, international medical graduates, who already have got a GMC registration, but they're completely stuck because they are lacking NHS experience. They don't get jobs. Employing them for 3 to 6 months with central funding is a no-brainer. It would be such an easy win. Portfolios, I can go on, but I think especially after the mishap with the internet, I'm running out of time. So last slide, I would just thank you all for listening. And yeah.
Thank you, Heike, very much. And we'll come back later to the question of the NHS support, NHS England support to Craig, if we may. Some questions in the chat are just pointing out, in fact, my old colleague Mirav Dover and also Fahira have been talking about the support that the Refugee Council give. Yeah. And I think the Building Bridges programme supporting refugee doctors, do you want to say something about that? And also, were there any, I mean, you talked about psychological support. How heavy was that? Did that need to be when you think of Yemen, when you think of Ukraine, when you think of Syria?
For us, I think it helped a lot. The Ukrainian group we had separately because we felt they had a unique set of very acute trauma. I think, but even as a group session, that was very helpful. And for Hira, yes, we've been working with Building Bridges nearly from the very beginning, and that's been a very, very exceptional relationship. And we're all here to help people to integrate and have a career in the NHS. And yeah, that was very important, I think, to link up.
Thank you. And I'm presuming that NHS England, Craig, and your outfit will come back to you on this, that in the guidance, there's also a lot of links to organisations that provide some kind of support. So perhaps, yeah, he's nodding. So we'll come back to that later. And then just finally, you did mention the Royal Colleges there. So how have you been able to make progress with the Royal? How strong were the links with the Royal Colleges, and have you been able to make progress with them? And it sounds
partly very strong, but still, I think it's a very rigid system that we have built up. And one example is perhaps not even the Royal Colleges, but foundation year training. Very, very difficult to have a sideway entrance into, for example, a foundation program.
Right.
I could explain more, that would be too complicated, but we've worked very hard and with very little progress with the official bodies.
Thank you. There is a question from Alana on this. Is there any support for junior refugee doctors who are required to join the foundation programme first?
This is exactly what I'm referring to. And we have had outstanding MSWs who then applied to New Zealand and Australia because they couldn't get anything in the UK. And I've spoken with the Dean for the foundation years, and it's been very difficult to make any progress. But I think it's a new scheme, so we need to recognise there's a lot of way to go. But we're only just starting to link up. But I think that would be very useful in the future.
Fantastic. Thank you so much, Heike. Again, we'll come back to you in the Q&A, most definitely. Thank you. muted myself. We're now turning to Dr. Inna Soldatenko, who is a Ukrainian doctor, who's going to be telling us a little bit about her experience and, in fact, of knowing quite a few Ukrainian doctors herself. Over to you, Inna.
Yeah, greetings to all. Thank you for inviting me. I am delighted to be here today representing Ukrainian refugee physicians. So the ongoing war in Ukraine has led to a significant influx of Ukrainian healthcare professionals seeking refuge abroad. These people bring invaluable expertise and a strong desire to continue their medical career in the UK. However, they encounter numerous obstacles, including language barriers, unfamiliarity with the UK healthcare system, and the complexities of regulatory requirements. Allow me to share a bit of my own story. So I resided in Kharkiv with my 2 daughters and worked as a consultant rheumatologist before the war broke out. I also had the privilege of serving as a PhD associate professor at one of Ukrainian's top universities for almost 15 years. But when my world turned upside down and losing everything you once knew and feeling as though the ground has been ripped from beneath your feet, it's indescribable feeling, to be honest. I arrived in the UK in May 2022 with nothing but despair waiting heavily upon me. I began to survey my surroundings and explore my options. As you may know, the bureaucracy in this country can be quite daunting. And I was completely overwhelmed. Then I realized that I had to pass numerous exams and spent at least 10 years in training to become a consultant again. And it seemed like an impossible task. One day, I put a post on Facebook and trying to find someone who is the same boat. As a feedback, in a few days, I became an admin of the Ukrainian medical community in Telegram channel. And today, we have more than 1,000 Ukrainian healthcare professionals all around the UK. I met Oksana Lyovichkina and Roman Gregg and began volunteering as a medical coordinator for the Ukrainian Medical Association for the UK. Now, we have subgroups of dentists, nurses, and doctors in our community. And all this time, we have been trying to collaborate with different authorities, such as General Medical Council, Nurse Medical Council, and unfortunately, less successfully with Dentist Medical Council. Also, in 2023, we established a Ukrainian medical charity. We aim to provide vital assistance to Ukrainian refugee physicians as they transition into UK healthcare system and foster their ongoing professional growth, providing vital medical supplies to Ukraine and offering assistance to rebuild Ukrainian healthcare infrastructure. Thankfully, I encountered kind-hearted individuals who went above and beyond to assist me in my own journey. And now I work as an admin for the Lewisham and Greenwich Trust, passed all exams from the first attempt and got GMC registration. However, I must acknowledge that my case is more than an exception than a rule. Currently, near 1,000 Ukrainian healthcare professionals can be involved in the NHS. Allow me to share some statistics with you. 96% of Ukrainian physicians aspire to obtain GMC registration. However, the journey is slow, with only 12% having passed the English exams and mere 2% having secured GMC registration thus far. The primary barrier remains language proficiency, with achieving the required B2 level proving to be a significant challenge. You may say that 18 months seems like enough time to learn English. However, due to the CFR achieving the B2 level requires 1,300 guided learning hours. Plus, according to Cambridge guidelines, for one guided hour, students need to spend 1.5 hours self-learning. I wouldn't say that my English skills before the war started were abysmal, not at all. Thanks to years of teaching based on European medical and British guidelines, I had a relatively extensive passive vocabulary. However, my speaking and listening abilities were merely at a touristic level and were absolutely insufficient for the exams. Thankfully, I stumbled upon Refugee Aid, and their constant support and guidelines with English learning courses for me and further for all our Ukrainian medical community were and continue to be invaluable. I would like to point out here that behind all these numbers lie real people, individuals forced to leave their country in search of safety for their families. We never anticipated becoming refugees. Ukrainian medics, and especially women skis, face the challenge of balancing English learning, exam preparation with our responsibilities of supporting children and elderly parents. Covering cost of living for someone who has lost everything can indeed be a challenging task. Moreover, the financial burden associated with exams and preparatory courses, despite the GMC discount, can be substantial. In light of all of this, the opportunity to restart the medical support worker program is a beacon of hope. This program offers a remarkable opportunity for us to contribute to the UK healthcare sector and familiarize ourselves with the NHS, especially when our expertise is greatly needed. We all understand that the ongoing war has created a clinical gap in the practice of Ukrainian doctors, and we're trying to find possible solutions to address this gap and help these doctors regain their confidence and competence in their medical practice as soon as possible. By supporting this program, you will play a pivotal role in facilitating the successful integration of Ukrainian refugee physicians in the UK healthcare system. This assistance will not only address workforce shortage, but also enhance patient care across the UK. To ensure a smooth transition for Ukrainian physicians, we kindly request your assistance in connecting us with the relevant teams responsible for supporting refugee healthcare professionals while they obtain GMC registration. On behalf of Ukrainian physicians, I extend heartfelt gratitude to all authorities and all partners for their invaluable support during this challenging time. Every effort have made on our behalf has been an enormous source of motivation, and from the bottom of my heart, thank you.
Thank you so much, Ina, and congratulations on your achievement with the GMC registration. But also, I think everyone listening can only be filled with compassion and wanting to support what you and your colleagues are trying to do, and as you stay in the UK, and just sympathies with what's happening in your country. I think everyone would say that. I just have one practical question for you, which is, from what you've said, if I understood that it is the English bar that is the most difficult, is that right? As opposed to the clinical bar?
Yeah. So the majority of our Ukrainian doctors, they're really struggling to achieve this B2 level. As I mentioned, it requires quite a lot of time. Yeah, and accordingly that we really have mostly women with kids here. Yeah, we need to cover cost of living, find a solution with school, etc. Yeah, so everything, and trying to find the job. And already, according to my statistics, it's more than 60% Ukrainian. There are unemployed Ukrainian physicians here right now, and only 10% they employed as for example, me, on a non-clinical role, but still an NHS. I can see how system works. Yeah, it's really beneficial for me, but most of them, they unemployed.
Yes, and I have to say, I'll put a link to people who are attending, but there was a very, very big feature in the New York Times about British Ukrainian doctors in Britain not able to work, and following some of them around some of the jobs that they're having to do. As Heike said about Sasha, an orthopedic surgeon who was working in a construction site or whatever it was. I mean, very well taken. Thank you very much for that. Okay, we'll come back to in the Q&A, but meantime, we will finish with our last speaker, who is Anthony Sambatia, who works at Northwest London, who is the project management for refugee recruitment for Northwest London, and he's based at West London NHS Trusts. But Anthony is going to talk to us about the initiatives that he's been leading to try to get a wider set of refugees beyond doctors who may be clinical trained or even not clinically trained into the National Health Service and contributing. So Anthony, over to you. Thank you. So sorry, Anthony, you're on mute. I apologise. Yeah.
Thank you, and good afternoon, everybody. Thank you for giving me this opportunity to share this information about the Northwest London Refugee Employment Programme. So the presentation I'm giving today is really covering 18 months of work. Although the program itself is about 2 years old, we spent the first 6 months setting up. And so the results that I'm going to share with you just cover that 18 months period. And let's go to the first second slide. So about 2 years ago, the UK experienced a drastic increase in the number of people coming in and seeking refuge and asylum as a result of wars in Afghanistan, Ukraine, Sudan, Yemen, Syria, and other places in the world. These people came in here and they were offered accommodation in various hotels, and some Good Samaritans accommodated them in their own homes. So around that time, the former chief executive of West London NHS Trust started receiving, she's called Caroline Reagan. She started receiving requests from individuals, refugees and organizations for opportunities to work in the NHS. So as a direct response, she set up this program, which is to recruit refugees into social care as well as into the NHS. So our aim really is basically to engage with those refugees that really want to work in the NHS and social care so that we can find them opportunities. And to do that, we had to set up a rapid recruitment pathway so as to support them and reduce these inevitable barriers, of course, including the DBS, the references, the long application form for the NHS, which is on the NHS jobs, and really supporting them to get work into the NHS. In order for the people that we've recruited into the NHS to stay, we needed to also offer the pastoral care. And pastoral care is really integral, as my previous speakers have said. People come with various problems which really need support for them to actually be retained and stay in their jobs. However, some of the people that we supported, asylum seekers, and for asylum seekers in particular, some of these people don't have a right to work in the UK, but they've been living in hotels for quite a long time. So we provided a project. We set up a project which was focused on volunteering and giving these opportunities to these asylum seekers, as well as refugees who have low confidence, who have employment gaps, but feel they want to work in the NHS as a starting, and this is how they would get into the NHS. So those are the objectives of our program. If you could move on to the next slide, please. So in terms of governance, I work for the Northwest London ICB, and I report to the program board for the refugee employment. This one comprises of NHS Trusts, local government, third sector, as well as the Department of Work and Pensions. We report into the Northwest London Population Health Board, but via the volunteering and voluntary sector board. We also have a reporting line with the human resource directors of Northwest London, because they help us with monitoring and supporting the actual recruitment of these refugees into the NHS trusts. If we could move on to the next slide, please. So this program, you can look at it as a challenge. I look at it as an opportunity. So it has its own challenges, but there are very many opportunities here. So if you look at that number in the middle there, which is 200,000, according to the United Nations Commission, High Commission for Refugees, there are 200,000 refugees and asylum seekers who have got a right to work and are living in the UK as of December 2023. And if you look at the last con, you'll see that we have just over 534 refugees and asylum seekers who are enrolled onto this program. 65 of those have got employed during this short time this program has been running. So the opportunities for you and everybody to look at those 200,000 and weigh it and think about it in terms of the number of vacancies we've got in the NHS and see if we can tap into that pool and then recruit them into the NHS. Focusing on the fact that this program is not recruiting doctors only or nurses only, it's recruiting everybody. We are talking about healthcare assistants, porters, project managers, financial analysts, IT people, everybody. Please look at that number and you'll see that there is a big opportunity if we can expand it. Let's move on to the next slide, please. So the breakdown of the people that we've recruited so far is like that. The majority of them are healthcare assistants. They are mainly at starting level. But for the purposes of this webinar, we've also recruited 14 doctors into the NHS trusts. There are some admin roles that have been received as well. Let's move on to the next slide. So we've been lucky to work with a number of fantastic partners, 8 NHS trusts. We've got quite a number of third sector partners, colleges, but most importantly, we've also got the DWP as our partners. We've got to notice that the majority of the people that we have on this program have been recruited from local job centers when they go in to seek universal credit. Let's move on to the next slide, please. So the benefits of this program are many, but I can really say that the majority of our beneficiaries on this program are people who are socially isolated, and this program gives them an opportunity to get better integration in the communities where they live. Secondly, the NHS has huge ambitions of getting to train and recruit and grow their own home talent. And this is really about getting people who are already living here and then recruiting them into the NHS and letting them grow into the structures. The other benefit of this is really for the local government. And for the local government, every individual that gets employed or gets into paid employment will automatically stop being supported. So this is a benefit across the local economy as well. But probably most importantly, the program is really about reducing inequalities for the people who are disadvantaged in our communities. I see faces of people whose confidence grows and whose self-esteem is increased as a result of getting jobs and volunteering opportunities from this program. Let's move on to the next slide, please. So this is a quick case study of one of the doctors that has been recruited on this program. He came into the UK from Libya in 2017 and gained asylum. He did a few jobs as he was doing his plabs and went through the MSW program at North Middlesex University Hospital, When this program started in 2022, we recruited him, but he was a referral from the Refugee Council. He managed to gain his GMC registration in July 2022, and West London NHS Trust recruited him as a trust doctor in October 2022. The senior leadership of the trust really put forward specific support for this individual to enable him be able to adapt into the mental health hospital environment. This individual is still working with us. Let's move on to the next slide, please. So, what can we do moving forward? So there are many doctors and other individuals that are looking for jobs, that are refugees, and there are some asylum seekers as well that have got the right to work. But for doctors in particular, we need to find a solution to prevent them from being de-skilled. These doctors who are refugees coming here, it takes them quite a long time between when they start preparing for their GMCs and actually passing those exams. It can take 3, 4, 5 years. At that point, many of them are de-skilled. We need to find a solution for that very urgently. Secondly, this program has been used or could be regarded as a pilot. So it has been a successful pilot. In the 18 months short period that we've been in existence, as I mentioned, we've been able to recruit 65 people. We've also been able to recruit 49 people as volunteers in the NHS. We've also been able to recruit 41 people and train them in employability skills. Some of those data is not on these slides, but it is there. And I'm happy to discuss this further. But we need to scale up this program to tap into the 200,000 people I mentioned, so that other ICB areas can also recruit refugees that live within their environments. This is when the real impact will be made, when we scale up. We also need to encourage and support retired doctors and nurses to become mentors for the refugees. Lastly, there is a program, which is the Volunteer to Career program. It's currently being supported by Help Force, which is a charity. We need to grow this program. This program is unique in that it gets people and gives them a pathway, but also a gateway into healthcare opportunities through volunteering. And it is working very well in Northwest London. This is something that we can tap into, and I encourage people to really support the Volunteer to Career program as well. Let's move on to the next slide, please. So, because this program of ours is focused on employing people from a wide range of backgrounds, but with different skill sets, I thought I should share this, this video. It's a short video, but the people you see in this video have all been recruited into the NHS and are working with us. Please play the video, and I welcome questions afterwards. Thank you.
Yeah, we might say the wrong thing.
No, you won't, so go ahead. So you were saying?
For me, I would say that it's an opportunity, because it has taken me like 1 year about the job recruitment with NHS, and it has been really a very big task. For instance, like us now, we've just got our refugee status. It has not been easier for us. They're asking us references, they're asking us experience. We don't have all that, and our dream is to work with NHS. So when we got this opportunity through our mates, my friend from Oxford University sent me this advert, said go quick. So I was very fast. Unfortunately, the person who sent me an email is Mr. Sembatia, Anthony. He's from Uganda, and I was so excited, and I've been communicating. And he said, immediately send me your CV. So I did that. So when I came in, I was looking around. So when he came here, I said, you're Mr. Anthony? He said, yes, I am. So we've met, it's really a pleasure, because we've met so many people. This was my dream, to meet professionals whom I can talk to, whom I can speak to. So now we've been able to put in our CVs, we've got good advisors. So hopefully this year or next year, we're going to be NHS workers.
Good, brilliant, absolutely brilliant. Thank you.
Thank you. I welcome any questions.
Thank you very much, Anthony. Another very inspiring presentation. So thank you so much for that. Just one quick clarification. Clearly, there is an issue about the MSW support scheme funding from NHS England, but the work you describe is wider than that. Who is supporting this locally? Is it the ICB? Is it the ICS? Is it a wider set of players? Who's funding this program?
Okay, so initially it was funded by Health Education England. They gave us a small grant, but since then the ICB has taken on the role, and I'm the only person employed in this program. So my post is funded by the ICB. But it's hosted by West London NHS Trust. And because of that leadership of the ICB, and of course support from NHS England, because we really engage with their nursing directorate quite a lot with their events, we really have that leadership and support, and that is how the program is working. But it's the ICB funding it internally through the Health Inequalities team.
Yeah, that's very impressive. And again, we've linked up to the ICB network and we'll do more after this and send them clearly this one. So thank you very much, Anthony. Now there's a few questions. We've got time for some Q&A. We've got two people on screen, you see, John DePiri and Masood, who haven't said anything yet. I was going to come to them at the end for next steps, but I think maybe just a minute or two from each of you on what you've heard so far before we kick off the discussion, maybe starting off with Masood, perhaps, and then going to John.
Thank you, Jennifer. First of all, I'm actually surprised and amazed by the level of support that refugees already getting across UK, and that's what something highlighted. I came as a refugee 40 years ago, and I came across two teachers in Paddington College who made their job to get me to medical school in an accelerated way within 18 months of arrival. Admittedly, I couldn't speak English then, and I learned English as I went along. If I'm forced to take a GMC exam today, English, I'm sure I will fail. So that's something that I think we need to come back to. But the one thing, Jennifer, the reason I'm very much thankful, there is a lot of discussion in UK at the moment about gap in healthcare, but there is very little about this resource which is wasted. And I think that you have, with the support of your team, you have brought this to attention of many people. It is human resources which is wasted in UK while we're going around the world trying to bring other people's. And I think this is a way to get through to taking the work that people have done and scale it up. If you look at the numbers, it's not substantial yet, but they are all can be built on. The hard work is done. There's no need to learn. It just need to scale up. And the scale up, I just give very quickly saying, we have 1,250 PCN. If 10% of them say next month, we would have one person in our organization. So 1 every 10 of them. And we have 215 trusts. If they just have one refugee on board. And do you know what? When I was a consultant in Kent, we used to find money from a League of Friends and somebody and set up fellowship. This is solvable. To absorb over 1,000 doctors in NHS is easy things for a lot of people. We need just people to stop from a point of waiting other people's help and say, I would find a consultant amongst 400 consultants in my trust, and I would start this program. So it comes down to 10 people per ICB to get this started. So if we're saying, my plea to you is, don't do it because you and anybody who hear this webinar on humanitarian basis. Put that aside. UK healthcare need this resource. We are desperate for resource. We need it for UK healthcare. And in order to do that, start small. If everybody in UK, in ICBs, about 10, in Trust 1 and PCN, just 10%, get up over the next couple of months and find one position and advertise it. And how we get that become a pool, how we get this to the refugees. I'm sure there are ways that they can send the email and this position as they come up to Craig or anybody else in these groups, and we can just disseminate, and I'm sure there is enough supply. You will not have problem with supply. You have a problem with the pool. So can I just make that as next step action for tomorrow?
Thank you so much. We'll come back to that in a minute. And I think, as Heike was saying, even if you have one person in your trust, there can be a network, an online network set up to try to help, share knowledge and good practice on top of the guidance that we've got. Thank you, Masood, for throwing the gauntlet down like that. So let's then have John have a few words, and then I'll come to the questions.
Thank you, Jennifer, and thanks also for hosting this with Health Foundation colleagues as well. So I guess my role here is to set this conversation in the wider context. Masood's call to action sits within a wider campaign that we've called 10,000 refugees into NHS jobs. And actually now we know the numbers, and we know the numbers of clinicians and wider refugees. This is a modest ask, so 10,000 refugees into healthcare jobs. We know that this is a population that is a real asset for the UK. As many speakers have described, they're resourceful, they're resilient. What they need is the dignity and agency through work that will enable them to contribute in the ways that we've heard throughout this meeting. So today we focused on MSWs as a route for clinicians to get into NHS work. But there's obviously that main conveyor belt of GMC registration, what you called the necessary high bar, Jennifer, which I agree with, but I think we do need to ask the GMC why it is that refugee clinicians are experiencing bottlenecks in the conveyor belt of registration, particularly around language. And they seem to be bottlenecks that are not being experienced in other countries, such as Ireland or France. So we do need to keep a focus on the GMC and how we're doing with capacity around particularly language. Additionally, I think there's a real opportunity around research roles in the NHS. And as you know, Jennifer, we will be talking to the Royal Colleges, and particularly the Association of Medical Royal Colleges, about whether there are opportunities for interim research roles for some of these amazing refugee clinicians who Ina and others have talked to us about. Then, as Anthony outlined, this wider population of refugees and the pathways through volunteering into multiple roles in our health service. And indeed onto the training pathways that we desperately need them on in order to meet those workforce gaps that I know, Craig, with your other hats, you're very focused on at the moment. So this all needs energy and some policy leverage at a time when, let's say, our politicians are quite distracted. So I'm really pleased that Masood, you, Jennifer, and others on this call are effectively mobilizing as a group around this banner of 10,000 refugees into health and care jobs. And I think one of our next steps will be to bring together a policy roundtable to really make the case for this incredible asset that we have in the UK refugee population, and to get commitments from the regulators, from our national bodies, and Royal Colleges to really move on this asset and make the most of it in the way that speakers have described. So that's my comment, Jennifer. Thank you.
That's fantastic. Thank you very much, John. So let's just turn to some questions and lock those up before we finish. There's one person who's asking, where are the refugee healthcare professionals in the country? Do we know where they are? Because people who will be on this call and listening may want to be able to proactively go out and seek and find them and help them in various ways with the language barriers or clinical placements. So I guess there's a quick answer from Craig. Do we know where a lot of these people are? But also to Heike, because you said, Heike, I think just by mere fact of word of mouth, you actually got quite a lot of people coming forward. So maybe we don't need a sort of map, and Inna as well. So perhaps Craig, Heike, Inna.
So yes, we do. We do know where the populations are. And we know there are concentrations in London, the Midlands, Leeds, and there are some, and Bristol was where the third main pocket is. So there is some intel we do get from Department of Work and Pensions and also DLUC as to the government departments. But Inna, I think might be able to share a bit more about how you can take that and actually into the more localized intel about where refugee populations are. I think that's what Inna's waving us, isn't it?
Yeah.
Yeah, to act on it. Yes.
Yes,
Maybe Inna then, yeah.
Yeah, as an admin of this Ukrainian medical community, yeah, so I know all the addresses and all names and all this they are based right now. Yeah, so it would be beneficial as well.
So before I go to Heike, has Craig, has anything proactively been sent to ICBs, ICSs with numbers or possible, no?
No, but it's one of those that as we're starting to look forward for sort of the next year, as we start developing some of our work programs out of the long-term workforce plan, there is going to be some focus on refugee work and connect up on some past stuff. And this is actually prompting a good action for me, Jennifer.
Thank you so much. And presumably the colleges might know, might they? And the BMA, the Refugee Doctor Initiative, they have 2,000 people that have contacted them. Maybe. Heike, anything more you want to add? Or Anthony, I can see you rolling your eyes.
Yeah, just to say, I can just confirm what Craig has said. And I think people tend to go to the big cities because that's where the support structures are. Because people come all by themselves without family, without pastoral support. So, of course, the conglomerates are in the big cities. And East London is saturated, it's full.
Yes, thank you. Anthony, did you want to add anything?
Yeah, just to say we know where these people are located, at least in Northwest London. I've got 68 doctors looking for work. If anybody on this call is interested, yeah, let's start with those ones. But there are...
That's great. Just looking to the other questions, there's still quite a lot about general practice, I think. And can we somehow tie in the GP induction and refresher scheme funded by HEE? Meaning, is there some special, given the fact there's an acute shortage of general practitioners, is there something more we can do here? Who would like to have a go at that?
So I'll start. I'll kick off, Jennifer. So so we did get quite a lot of learning through like the MSW program when it was nationally funded about how this scheme best interfaces into primary care and actually some of the benefits of it. Now, I think one of the gifts of with NHS England and Health Education England having now come together, we are working much more closely. And I think that suggestion around the link into sort of GP induction and some of the other education schemes could be beneficial. So again, I think there's another thread where somebody's actually raised something that we actually think these are dots now that we need to start joining up. So if we're going to support providers to actually adopt this and actually take this forward locally and empowered, there are some other bits that we need to, I think, square in terms of those joins. And so primary care is a focus for me. So thank you again.
Thanks very much. And then there's a question here about the support available for MSWs, particularly psychological support. Now, we spoke about the Refugee Council support earlier and the clinical psychology team that Heike talked about. But someone is saying that occupational health teams in trusts often don't know what psychological support services might be available. Is there any way that somehow that could be socialized amongst occupational health in trusts? who have refugee doctors or indeed IMGs? Sorry, Craig, that's you again.
It is, but I think this is one of those things that there's been quite a lot of work that NHS England has done, certainly throughout the pandemic, around creation of psychological capacity and capability within organisations around that support. And I think probably what that we will have to do is actually do some repointers back to those key resources and actually access points for psychological support, because it does exist, it is out there. If there are occupational health providers that are unclear of that, then I think probably what that prompts me is to talk to one of my colleagues saying I think there's benefit of us doing more common cascade on sort of the availability of those resources.
Fantastic, thank you. And there's quite a few questions about English support, and particularly directed to Anna, yes, about what other support might be available to help people with this English exams.
As I mentioned, as a Ukrainian medical charity, we collaborate with Refugee, and they provide for us different English schools or courses, online and offline, depends on the circumstances, our refugee physicians. But it has a queue, quite a long queue, to step in and start these courses, unfortunately. And but according to my statistics, our doctors mostly already have B1 level, and it's absolutely enough to communicate, in an absolutely sufficient level. And I think we all may agree that being in the medical environment, it could give a booster, their medical English and medical knowledge. So I think this medical support worker program is a really great opportunity.
Thank you. I'm so sorry. Yeah.
DWP just allocated £2 billion to get people back to work. Now, why we can't get 40 million of that to NHSE to get this the MSW up and running again? And now we have got all of the work done as a background. We scale this up. I mean, is there something a structurally obstacle, or this is something that one can pick up later?
Yes, good points. So at a strategic level, and just to say, we will follow up this webinar with some roundtables, won't we, Masood and John and Craig, to try to get some of the key national players together to try to bust some of these barriers that we're describing here today. So we've only got 5 minutes to go, and I do want Craig to be given chance to talk about the next steps in particular, I think. And I'll turn to Masood and John also if there's anything final you would like to add. But Craig, I mean, there's quite an agenda here, isn't there? And I think everybody understands and sympathises with the NHS England's financial position for the health service. But tell us a little bit about where you think we go from here next, given what has been described today.
Yeah, so I think where we go from here, Jennifer, is that I want to create more narrative in the system about the importance of these schemes and actually the benefits that it delivers. I think Masood's call to action in terms of, if you just take forward one refugee and give
one person
and give them an exceptional experience, that is one more person that is actually entering the NHS workforce, and that can be then scaled further. A lot of the legwork has been done in terms of the learning. The resources are now there. So my ask here is for those that are on this call is, when we publish up, when we share where the resources are, go take a look. I think inspire that conversation in your organisation to say, we have something that we can give here, and there is talent. There is talent out there and people with exceptional skill that can contribute to the NHS. And I think my ambition is, how do we bring new and different people into the NHS and remove the barriers and actually remove some of the process? So my next steps here is, arising out of this, there are some bits we've got to do in terms of further join up. We are going to do more comms and promotion of this. The resources are there. The next step also is, I think, that round table about to inform and actually expand that policy discussion, and also to actually add this into our planning in terms of certainly our national programme of work through the long-term workforce plan, about how do we actually do more in terms of expanding the access points to medical careers. I think that's probably a summary in terms of a number of things that I and my teams will be taking forward, but also there is the actions for others on this call. So let's get this moving. It's an investment of a minimum of a band 6, plus the education support that sits behind that as a starter. It's not a lot when you give out in cash terms.
Yes, that's a really good call. Thank you. So what we will do after this webinar is on the part of the website where you found the webinar, or the Health Foundation's website, we'll put a lot of link to some of the resources that we've heard about today. Certainly all the slides, clearly the webinar recording, but also some of the guidance, Craig, if we could put that on as well, as much as we can, and anything that you and Anthony, Johan, Heike, all that stuff in one place. I think the call to our arms, Masood's call to arms there, I think is a really practical one. And I think really that in terms of understanding and helping people, I think that's really Craig's department, isn't it? Because it's a kind of, not so much coordination, but it's helping people to collaborate and learn from each other and find access to resources. So I will have to leave that with Craig. But I think those are at least some starts. And as promised, we will take forwards at least one or two roundtables with some of the key players on some of these thorny issues, the English Bar 2, Level 2, which Inna is very cogently describing, the Royal Colleges and the foundation sort of spaces, the length of time that the GMC process takes. I think that's another one, isn't it? I think those are some of the immediate things to take forwards. But I have to say, I'm taking away so much from today's practical as well as inspirational. And I think Anthony's mountain of the 200,000 is a really good one to start, place to start and hold in our heads, as well as Masood's challenge to us all, I think. Masood, John, do you want to say any final last words before the curtain comes down?
I don't have anything to add, Jennifer, but Masood, 40 years ago, was a refugee. I think flipping this population from being a dependent population, we
yes.
see on this call what an asset they are to our health service and our society. So my role to unbung some of the policy levers on this, I hope.
Thank you. And Masood, spare your blush, Masood became a consultant ophthalmologist in the NHS for many years and also founded one of the bigger companies in the UK as well. So it gave back in many ways, didn't you, Masood?
Thank you very much.
Fantastic. We better end. The curtain will come down in a second anyway. Many, many thanks to our inspirational guests today, the panelists. And check our website, check the recording, check the resources. And Craig is your man to take forwards in terms of practical things. But in the meantime, many thanks indeed. And see you shortly and soon. More on this later. Bye. Bye-bye, everyone.
Bye.
Thank you.